So good afternoon, ladies and gentlemen. Welcome to Monterey Symposium. So first of all, please allow me to introduce our wonderful moderator, Professor Sheila Mitra. So Sheila is a professor, the chair of the Department of Anesthesiology, Critical Care and Pain Medicine. She works in Tata Memorial Hospital, Mumbai, from India. Welcome, Sheila.
Thank you so much, Dr. Fiona New. And Fiona, as you all know, is the director of PMLS Global Marketing for Mindray. And we're all here for the Mindray Symposium. It's great to see a hall full. I request all of you to please take your seats so we can start this very exciting session. It's on delivering safe oxygenation and improving mechanical ventilation and CIIA in the OR, so you're going to see and learn something new. And we have two excellent speakers, experts and doyens in the field, who are going to be speaking in this oxygenation session. So without any delay, I'd like to introduce our first speaker. Professor Daniel Talmor is known to all of you. He's the Edward Lowenstein Professor at Beth Israel Deaconess Medical Center in Boston, and he's also the chair of the Department of Anesthesia, Critical Care and Pain, and professor at Harvard Medical School in Boston in US. And he's going to be speaking to us about how we could improve preoxygenation for safer intubation by combining two techniques, that is high-flow nasal oxygen and other oxygenation techniques. Over to you, Professor Talmor.
Thank you. Thank you for that kind introduction, Sheila. So I'm not Samir Jaber, who was supposed to deliver this talk, and I'm sure that's disappointing, but I will do my best, and any problems with the presentation are mine because the slides are excellent. Can we get the show up? Yeah. Okay, well, I'll just pass the time here while they're getting the slides up. I'm very excited by this symposium because for many years an anesthesia machine was an anesthesia machine was an anesthesia machine. And we are starting to see some real innovation in the way that products are added to the anesthesia machine. And really the topic of this symposium is the added value we're seeing in anesthesia machines and how we can better leverage those added features to deliver excellent patient care. And I'm going to be talking about two aspects of this. So starting with the addition of high-flow nasal cannula to the anesthesia machine, the ability to deliver high-flow oxygen before and after the surgery. And then I will be talking later on about jet ventilation, which is a mode of ventilation that we've talked about a lot. We see it used occasionally, but now that it's in the operating room on our anesthesia machine, it really opens up additional possibilities.
Okay, we're ready to start. Sorry for that little technical problem.
Yeah, apologies
Over
for
to
that.
you.
So, without further ado, improving preoxygenation for safer intubation by combining two techniques of preoxygenation in the OR and in the ICU. So as I said, this is Samir Jaber's presentation, and I'll be filling in for him. So the objectives of the talk are how do we improve preoxygenation in the operating room. Preoxygenation, as we'll see, is a critical component of our anesthetic. We'll talk about the rationale of combining techniques. We'll talk about the OptiMask trial, an excellent example of an industry academic collaboration in a trial, the upcoming OptiNeve trial, and some key messages. So what's our goal in preoxygenation? It's to improve the oxygen reserve in the lung. And in healthy lungs, this is typically not a problem. We can increase the oxygen content in the lung from 100 to 400 within 3 minutes. We denitrogenize the lung, we improve the oxygen reserve, and we supply the reserve for intubation. Now, in sick patients, this can be more difficult. So in a patient who's ill, has chronic lung disease or acute lung disease, it's very difficult to bring up the oxygen in the lung with standard preoxygenation. So we need to try to do better. Now, preoxygenation is not the only component denitrogenation is not the only component of preoxygenation. We want to try to prevent the formation of atelectasis during intubation. And this is a ubiquitous thing. Everybody develops atelectasis during intubation. We stop the patient's breathing, the lungs start to collapse. We see that collapse immediately, and that collapse continues into the postoperative period unless we can try to do something about it. So you can see here CT evidence of collapsed lung immediately after induction. Now, standard preoxygenation won't prevent that, because with standard preoxygenation, I put a face mask over the patient. They may breathe spontaneously. I may give a couple of breaths, but eventually I'm going to take the mask off, and the patient is going to be apneic, and the lungs will collapse. So that atelectasis will form. However, if I apply continuous positive airway pressure to the lung around the intubation, and it doesn't have to be a lot, it can be a minimal amount, and here is an example with 6 centimeters of water, we can prevent the formation of atelectasis during intubation. This will improve the patient's postoperative pulmonary outcome. Now, atelectasis, hypoxemia, those are bad, but worse is cardiac arrest and mortality. And there is an association between hypoxemia and cardiac arrest in the perioperative period. And no preoxygenation or inadequate preoxygenation in sick patients is highly associated with cardiac arrest. So it's even more important that we pay attention to this critical time of preoxygenation. And it's something we all sort of take for granted. We want to get the case started quickly, we want to get the tube in, but we need to do it properly in a way that prevents risk to the patient. And if you'll notice here, underneath the red box, overweight and obesity is also a factor for perioperative cardiac arrest. And one can imagine that that's because of the weight of the chest wall pushing down on the lung, increasing the atelectatic areas, decreasing the patient's oxygen reserve, and further exacerbating lack of preoxygenation. So how can we do it better? And one of the ways we can do it better is by not just simply doing what we always do, but by considering how we can improve our preoxygenation. So, the usual care is a standard face mask. There have been studies looking at high-flow nasal cannula during the preoxygenation period. Non-invasive ventilation also has been used, but perhaps if we combine 2 methods, it's better than one. So 2 methods, you can see number 4 there, that is the OptiMask trial, recently completed with the support of Mindray. We're adding to the standard face mask and bag, we add high-flow nasal cannula. And that's easy to do because it's integrated to the anesthesia machine. In the ICU, we can be a bit more sophisticated, and we can add non-invasive ventilation, or CPAP, to high-flow nasal cannula. And that's the OptiNeve study that's coming up. So we're going to talk first about OptiMask and then about OptiNeve. And by combining 2 methods, so you can see number 4 there, OptiMask, I'm able to deliver high oxygen concentration. It works before laryngoscopy when the patient is breathing through their mouth, but it also allows apneic oxygenation while the patient is not breathing and while I'm doing laryngoscopy, okay? It also allows, that doesn't really allow positive pressure ventilation, although there is some positive pressure delivered by the high-flow nasal cannula. But OptiNeve in the ICU will add positive pressure ventilation through non-invasive ventilation. So 2 techniques combined together, better than one, and allows us to achieve appropriate preoxygenation. So what is the evidence to support this? This topic has been circling around for 10 or 15 years. In You can see here this patient, this study by Samir and group, one of the first ones, demonstrated the effectiveness of non-invasive positive pressure ventilation for preoxygenation in morbidly obese patients. And you can see that facial mask and pressure support mode with PEEP improved preoxygenation prior to the planned intubation. And on the right-hand side, you see the improved oxygenation. On the left-hand side, you see the number of patients with a expired O2 of greater than 95%. The purple is the combined technique, and it was much better, so much less desaturation around intubation. So let's talk about OptiMask, the study in our OR patients. So this was the publication. It was published in the Annals of Intensive Care, tri-national study between France, China, and the United States, and supported, as I said, by Mindray. Now, the goal was to evaluate the effectiveness of the combined method of preoxygenation using a standard face mask and high-flow nasal oxygen. So we called this OptiMask. And the outcome measure was the lowest end-tidal oxygen within 2 minutes following intubation. So end-tidal oxygen is an excellent measure of how well the patient is oxygenated. So the hypothesis was that by combining methods, and you can see this on the left-hand side, maintaining the high-flow nasal cannula throughout the induction. Okay, so we put the nasal cannula on, turn it up, put the face mask on, that would be better than standard face mask alone. So here you can see preoxygenation before the laryngoscopy, and on the right-hand side, the nasal cannula continued to flow during the laryngoscopy. So that continues the oxygenation and also adds a certain element of positive pressure to prevent the atelectasis that we could see. So combining methods, two better than one. And we're able to do that, as I said, because the new Mindray anesthesia machines have high-flow nasal cannula integrated into the machine, so you don't have to go and find an additional device. So these are the results. The primary endpoint was the lowest end-tidal O2 within 2 minutes after intubation, so a very simple outcome, and it was better in the combined method, okay? So the combined method, we did not see really desaturations or end-tidal O2 less than 88%. In patients without obesity, the signal really was there, but not too strong. But when we looked at the obese patients, and those are the ones who are going to desaturate the most, as the pressure from the chest wall pushes down on their lung, in the obese patients, there was a really substantial and important difference in oxygenation using the OptiMask protocol. So combining methods of preoxygenation really improved the outcomes in obese patients. And here's the number of events of SpO2 less than 95%, and it was much fewer in the OptiMask protocol. So not only the end-tidal O2, but the actual saturation was much better. So following up on that, you can see this is basically a whole research agenda around this question of combined preoxygenation. And OptiMask is down there in the second to last row. We'll follow up with the OptiNeve, combining non-invasive ventilation with high-frequency nasal cannula. And you could see how this could also be done in the operating room by combining using a real non-invasive mask during intubation. So the OptiNeve study, this is based on this paper, again by Samir, who's done a lot of work in this area. They compared, in this first paper, standard preoxygenation using a mask valve device and non-invasive ventilation for preoxygenation. And they were able to show that the non-invasive ventilation was associated with much less desaturation. And it's important to see the scale here. So in the standard bag mask valve preoxygenation, the SpO2 went down to 80%, okay? That's, you know, we've all been there. We've all had that sort of terrifying feeling hearing the beep change of the SpO2 and hearing it start to sink and the patient become bradycardic. We can prevent that using non-invasive ventilation. High-flow nasal cannula, on the other hand, has also been shown to improve oxygenation during preoxygenation for intubation in the ICU. The OptiNeve will combine the two to try to get even better and better outcomes. So here you can see this is preoxygenation with non-invasive ventilation. During laryngoscopy, you're going to have a period of apnea, which again will lead to desaturation and atelectasis. In the OptiNeve trial, will include high-flow nasal cannula and non-invasive ventilation to improve preoxygenation in the ICU. And preliminary data shows that this is a much better combination. So you can see saturation using the combination of the two essentially maintains 100% during the intubation. So if we look stepwise, and these are minimal SpO2 levels, and you can see the various studies. Oxygen through a face mask, we see levels in the 85 to 90% range. High-flow nasal cannula does a little better. Non-invasive ventilation does a little better. But really the solution is combining methods now possible in our new anesthesia machines. So the key messages are OptiMask in the operating room, combining high-flow nasal cannula and standard face mask. OptiNeve for the sicker patients in the ICU with high-flow nasal cannula and non-invasive ventilation. Combining, we have to really change the classical paradigm of using one type of preoxygenation. Let's combine them, get the synergistic benefit of two types of preoxygenation, and to get a better outcome for our patients. Thank you very much.